Welcome to the funnel effect. And before we dive into what is arguably the most significant shift in pulmonary embolism management in over a decade, I need to read the full attribution for the document we are analyzing today because, honestly, the weight of this expertise really matters here. This is the 2026 AHA-KEKSEKCHES VMSVN Guideline for the Evaluation and Management of Acute Pulmonary Embolism in Adults.
That is a lot of acronyms.
It is a massive amount of acronyms. And to give you the full picture, this document is a report of the American College of Cardiology and American Heart Association Joint Committee on Clinical Practice Guidelines, developed in collaboration with the American College of Clinical Pharmacy, the American College of Emergency Physicians, American College of Chest Physicians, Society for Cardiovascular Angiography and Intervention Society, of Hospital Medicine Society, of Interventional Radiology Society for Vascular Medicine, and the Society of Vascular Nursing.
Just an incredible coalition.
And here are the minds behind the operation. The writing committee members are Mark A. Krieger, Chair, Jeffrey D. Barnes, Co-Vice Chair, Jay Geary, Co-Vice Chair, Deborah Brada Mukherjee, William Schuyler Jones, Allison E. Burnett, Teresa Carmen, Anna I., Castanegro Lane Castellucci, Cheryl M. Clark, Mary Cushman, Kirsten DeWitt, Jennifer M. Eves, Margaret C. Fang, Joshua B. Goldberg, Stanislav Henkin, Hillary Johnson Cox, Sabita Kadavath, Daniela Kadian Dudov, William Brent Keeling, Andrew J. P. Klein Jun Lee, Michael C. McDaniel, Lisa K. Moores, Gregory Piazza, Karen S. Pranger, Stephen C. Pugliese, Mona Renaid, Rachel P. Rosovsky, Forla Russo, Eric A. Sachevsky, Akhilesh K., Sista Levin Tefera, Ida Weinberg, Lauren M. Westifer, and Michael N. Young.
I am out of breath just listening to that.
I know, right. Okay, let's take a breath and unpack this, because that was a mouthful. Honestly, it felt a bit like reading the credits of a Marvel movie, but for blood clots. But when you actually listen to that list of organizations, you know it hits you. You have emergency medicine, pharmacists, surgeons, radiologists, nurses. It really sets the stage for the complexity we're dealing with. Pulmonary embolism, or PE. It isn't just a heart thing or a lung thing. It's an everything thing.
It absolutely is. And honestly, hearing that list, it's grounding. Because it reminds us that PE management has historically been a bit of a turf war.
Oh, for sure.
Yeah, you had different specialists seeing the exact same patient through very different lenses.
Yeah.
The surgeon wants to cut, the radiologist wants to catheterize, the internist just wants to medicate. The fact that all these societies from, vascular nursing to interventional radiology signed off on one single document is a monumental achievement in consensus. It's essentially the medical equivalent of a peace treaty.
A peace treaty that is bringing us something brand new. Because we aren't just looking at a minor update here. This is a de novo guideline for 2026. It replaces the old frameworks we've been using since 2011 and the updates from 2019. It really feels like we are finally modernizing the approach.
That's right. And the reason this is happening now in 2026 is because the old way of doing things was becoming, well, let's call it a blunt instrument.
A blunt instrument. I like that.
Yeah, for a long time, we treated PE with a very binary mindset. It was almost primitive. You either had a massive clot that was killing you right this second, or you had a clot that wasn't. But biological systems are rarely that black and white.
Right. It's like trying to describe the weather by only saying it's either sunny or it's a hurricane.
Yeah.
There's a whole lot of storm activity in between those two extremes.
Precisely. And that in between is where patients were getting lost. They were slipping through the cracks of our nomenclature. So the core mission of our deep dive today is to understand how we're moving away from those vague, clumsy terms like massive and submassive.
Which, let's be honest, were always super confusing.
So confusing. And we are moving toward a precision 5-tier alphabet system. We are talking categories A through E. This changes everything from who gets to go home immediately from the ER to who gets rushed into emergency surgery.
So we're trading in our vague adjectives for a report card. A through E. I like it. It feels structured. But before we get into the nitty-gritty of the letters, I want to go back to that blunt instrument ID you mentioned. You said massive and submassive. Can you unpack how doctors used to talk about PE? Because submassive always sounded to me like almost huge.
I know it was intuitive linguistically, but clinically it was a mess. If we look back at the 2011 AHA guidelines, the world was essentially divided into 3 parts. You had massive PE. That didn't mean the clot was physically big. It meant the patient was in shock. Their blood pressure had tanked and they were actively dying.
Okay, so massive equals crashing.
Exactly. Then you had submassive, which meant the blood pressure was fine, specifically the systolic was over 90, but the heart was struggling on an ultrasound or blood test showed heart damage. And then finally, you had low risk.
Okay, straightforward enough on paper. Shock, strain are fine.
In theory, yes. But then The Europeans, the ESC, came out in 2019 and tried to refine it. They gave us high, intermediate, low, and low. They tried to slice the bologna a little thinner.
That's a lot of hyphens to remember in an emergency room.
It is, and the fundamental problem persisted. These terms were insufficient because they didn't capture the dynamic nature of the disease. They completely missed the patient who isn't in shock yet but is standing right on the precipice.
No, the pre-shock state. The patient who looks okay when you walk in the room. Maybe they're sitting up chatting with you, but biologically their systems are redlining and they are about to just fall off a cliff.
Exactly. We were reacting, not proactively treating. And on the flip side, the old guidelines were also terrible at identifying the patient with a tiny clot found completely accidentally who really, truly doesn't need to be in a hospital bed.
So we were overtreating the small stuff, exposing people to hospital-acquired infections and massive bills they didn't need.
Right. And potentially under-recognizing the impending disasters on the other end of the spectrum.
So enter the 2026 innovation. The AHA, ACC, Acute PE clinical categories. We have A, B, C, D, and E. It feels like a hurricane warning scale or maybe a triage color code. But why do we need 5 buckets? Is it just for the sake of academic complexity?
No, it's for the sake of matching the treatment to the actual threat. PE presents on a massive spectrum. We need 5 buckets to accurately stratify that risk for you. If you just have big clot versus small clot, you miss all the nuance. This new system integrates everything.
When you say everything, you mean all the clinical data,
Right. Clinical symptoms, how the patient actually feels. Hemodynamics, their blood pressure and heart rate. Respiratory status, are they gasping for air? Biomarkers, those blood tests like troponin and BNP that tell us if the heart is crying for help. And imaging looking specifically at the right ventricle size. You put all that data into the funnel, and out comes a letter.
And that letter dictates your destiny.
In a clinical sense, yes. It dictates whether you sleep in your own bed tonight or on an operating table.
Now, before we walk through the actual letters, there is one crucial tag-along I saw in the guidelines that caught my eye. The R modifier. It sounds like a sports car model, the category C3R. What exactly is the R?
The R stands for respiratory. And this is a crucial addition that solves a major historical blind spot. In the past, we focused heavily on blood pressure, on hemodynamics. We were obsessed with the heart as a pump.
Because if the pump fails, you die. Makes sense.
Right. But there are patients who have a rock-solid blood pressure, yet they are suffocating. The R modifier is applied if a patient has hypoxemia, meaning an oxygen saturation less than 90%, or a respiratory rate over 30, or if they require high-flow oxygen just to keep their levels up.
So you could be a Category C patient because your heart's strained, but if you're also gasping for air, you get the R stamp.
Correct. You'd be a Category C3R. It flags to the entire medical team that while their heart might be the primary structural concern, their lungs are also failing. It ensures we don't ignore respiratory failure just because the blood pressure cuff says a 120 over 80. It forces us to look at the lungs again.
It's adding a layer of detail that was frankly missing. And it makes total sense. It is a pulmonary embolism after all. So let's start at the beginning of the alphabet. Category A, this is the subclinical category. Now, wait, so I can have a pulmonary embolism and not even know it?
You absolutely can. And honestly, with modern imaging technology becoming so incredibly sensitive, we are finding these more and more often. Category A is defined strictly as an incidental and asymptomatic PE.
Incidental, meaning I went in for something else completely unrelated.
Exactly. Let's say you're a cancer patient getting a routine staging CT scan just to see how your tumor is doing.
Yeah.
Or you were in a minor car accident and they scanned your chest in the ER to look for broken ribs.
Right, they're looking for bone damage.
Yeah, and the radiologist is scrolling through the images and calls down to the ER doc to say, hey, by the way, there's a small clot in the far periphery of the lung. You have no shortness of breath, no chest pain. Your heart rate is totally normal. That is Category A.
And in the old days, that person might have been admitted to the hospital, right? Just out of fear.
Often, yes. Because the word embolism is scary. It triggers a visceral reaction. Doctors are trained from day one to fear PE. But the 2026 guidelines are very clear here. Category A patients can often be discharged home directly from the ER. No hospitalization needed.
So you just give them medicine and wave goodbye.
Pretty much. You treat it with blood thinners, sure, but you don't need to take up a hospital bed for that.
That is a huge shift in resource utilization. If you're fine, you go home.
Okay, moving to Category B. Symptomatic, but low risk. So I have symptoms, maybe a little chest pain, a little shortness of breath, but you're saying I'm still statistically safe.
Safe is a relative term in medicine, but yes, statistically very safe.
Yeah.
Category B is for the patient who knows something is wrong, they feel it, but their body is handling the stress well. To be in Category B, you must have what's called a low clinical severity score.
And this is where we get into those acronyms that doctors love so much. The source material mentions the PC score, right? The Pulmonary Embolism Severity Index, or PSI, or the simplified version, appropriately named SPSI, or the Hestia criteria. These aren't just random letters, they are highly validated checklists.
What exactly are they checking on these lists?
They look at things like age history of cancer, heart rate oxygen levels, mental status. If you score low, meaning class 1 or 2 on the PC, or straight 0 on the simplified version, the data shows you are statistically at very low risk of dying or crashing in the next 30 days.
And the guidelines break Category B down further right, into B1 and B2.
They do, and this is interesting for the anatomy nerds out there, but also for treatment decisions. B1 is subsegmental. That means the clot is way out in the tiny, tiny branches of the lung tree. It's a twig, not a trunk.
And B2?
B2 is non-subsegmental, meaning the clot is in a larger branch, but the patient is still chemically and physically stable.
But regardless of whether it's B1 or B2, the big recommendation here is the same as Category A.
Mostly, yes. The recommendation is Class 2A for early hospital discharge. The shift in mindset here is treating PE like we treat DVT, deep vein thrombosis.
Oh, right. If you have a clot in your leg, we just give you a pill and send you home.
Exactly. We don't admit you for a leg clot unless there's a complication. The guidelines are essentially saying if the patient is a Category B and their home environment is safe, meaning they can physically get the medications, they can understand the discharge instructions, they aren't totally socially isolated, then they do not need to sleep in the hospital.
That is the home versus hospital revolution right there. Categories A and B effectively clear out the ER waiting room of people who just don't need to be taking up acute care beds.
Yeah.
But now we cross the line. We enter the territory where things get murky. Category C.
Category C, the middle child of PE.
The middle child always has it rough. It's the tricky zone.
They do. This is by far the largest and most heterogeneous group. Category C is defined as symptomatic with elevated clinical severity. So your PC score is high, maybe over 85, or your simplified score is 1 or more. You have risk factors that say, hey, this person is fragile, maybe they're 85 years old, maybe they have active metastatic cancer.
But they still have normal blood pressure.
Yes, they are hemodynamically stable, but their body is working hard to maintain that stability. Now, Category C is where the precision of this new guideline really shines because they don't just lump them all together. They split it into C1, C2, and C3 based on how angry the heart is.
Okay, walk us through the levels of anger. Let's start with C1.
C1 is the mildest of the dangerous group. You have a high-risk score. Maybe you're older, maybe you have cancer, but your heart function is perfectly normal on imaging and your troponin levels are normal. So the soil is bad, meaning the patient is frail, but the clot's actual effect hasn't strained the heart yet.
Got it. High-risk patient, low-stress event so far. What's C2?
C2 is where we see one of two things. Either the right ventricle, the RV is struggling, it looks a bit on the CT scan, or the echocardiogram or R, the biomarkers are high. You have elevated troponin or BNP in the blood.
Okay, troponin is the heart attack enzyme, right? Why is it showing up in a lung problem?
That is a great question. It leaks when heart muscle cells are dying or under extreme stress. In PE, the clot blocks the blood flow in the lungs. The right ventricle, which is the chamber that pumps blood directly to the lungs, suddenly hits a brick wall. It has to push way harder against that blocked pipe.
Because the pressure in the lungs has spiked.
Exactly. The pressure builds up. That pressure stretches the right heart muscle, causing microinjury, and troponin literally leaks out of the damaged cells. So C2 is what I call one bad sign. Either the picture looks bad with RV strain or the blood looks bad with troponin.
And I'm guessing C3 is both bad signs.
You guessed it. C3 is right ventricular dysfunction, A and D elevated biomarkers. This is the patient who is technically stable. Their blood pressure is holding up, but their heart is screaming. It is totally maxed out.
This sounds incredibly precarious. If I'm a C3, I'm walking around talking, my BP is a perfect 110/70, but my heart is actively leaking enzymes and ballooning in size inside my chest.
Yes. And that is why C3 is so scary for clinicians, because that stability is a facade. They are using every ounce of their physiologic reserve just to stay stable. If they sneeze, if they walk to the bathroom, if they bear down, they could tip over into Category D or E in a heartbeat.
So the clinical implication for Category C is do not send them home.
Absolutely not. These patients need hospitalization. They need to be monitored closely for deterioration. You are watching them like a hawk because they are the ones who can really surprise you on a Tuesday night. A C3 can become an E in 5 minutes flat.
Okay, so C is the watch closely group. Now we move into the territory where the alarms really start ringing. Category D and E. Category D is listed as incipient cardiopulmonary failure. Incipient is a fancy word. What does it actually mean in this context?
Incipient means beginning to happen or developing. This is the pre-shock state. And honestly, Category D is probably the most important contribution of this 2026 guideline to saving lives.
Really? More than the E category, why is D so important?
Because it captures the patients we used to miss entirely. In the old massive versus submassive world, you had to have drastically low blood pressure to be considered massive. If your BP was normal, you were lumped into submassive. But Category D identifies the patient who is technically normotensive. Their blood pressure is fine, but they are biologically in shock.
This sounds like a contradiction. How can you be in shock if your blood pressure is normal? I thought low BP was the literal definition of shock.
That's a very common medical misconception, actually. Low BP is the result of uncompensated shock. It's late stage. But shock at a cellular level just means your organs aren't getting enough oxygen. Category D has two flavors to help us spot this early. D1 is transient hypotension. Their BP dropped, the nurse gave them some IV fluids, and it popped back up.
So it's fixed.
No, that is a warning shot. You do not ignore that. It means the pump faltered for a second, the system is failing.
That's the body flickering like a dying light bulb.
And D2? D2 is normotensive shock. This is the silent killer. The blood pressure number looks beautifully normal, maybe 100/60, but the patient is confused because their brain isn't getting enough flow. Their urine output has completely stopped because the kidneys have shut down to save water. And crucially, their lactate level is high.
Lactate, that's the chemical your muscles make when you sprint and run out of oxygen, right? The lactic acid burn.
Exactly. It's a marker of anaerobic metabolism. If you are just laying in a hospital bed doing nothing and your lactate is high, it means your body is suffocating from the inside out. Even if your blood pressure cuff says you're perfectly fine, your body is clamping down all its blood vessels, vasoconstriction, to keep that pressure up, sacrificing the gut, the kidneys, the skin just to save the brain and the heart. It is a desperate temporary fix.
Wow. So in the old guidelines from a few years ago, a D2 patient might have been sitting in a regular room on a general ward because, hey, the BP is fine, right? Now they are red flagged as incipient failure.
Correct. And recognizing D2 allows us to escalate care before the catastrophic crash. Because once they finally exhaust that reserve and crash, they enter Category E.
Category E, the end of the line, cardiopulmonary failure.
This is the classic massive PE. E1 is cardiogenic shock, persistent low blood pressure that IV fluids won't fix. They need continuous vasopressor drugs just to keep their heart pumping. And E2 is refractory shock or cardiac arrest. They are actively dying or have died and been resuscitated.
The action plan here is obviously immediate. There's no waiting and watching in E2.
Immediate advanced therapy. We aren't just giving pills or standard shots here. We are talking systemic thrombolysis, emergency surgery, or putting them on ECMO, the external heart-lung machine.
It's a terrifying progression, but breaking it down from A to E really visualizes the slide from incidental finding to cardiac arrest. It forces the medical team to be incredibly precise about where the patient is on that slide.
It forces us to look at the whole patient, not just one number on a monitor. You can't just treat the machine. You have to treat the underlying physiology.
Speaking of the medical team, let's talk about who is actually making these life or death decisions. Because traditionally, medicine has these deeply ingrained silos. The ER doc sees the patient first. The cardiologist might be consulted later. The surgeon is upstairs in the OR. They might all disagree on whether a patient is a C3 or a D1 or what to do about it. The ER doc might want to push drugs while the surgeon might want to cut.
That brings us perfectly to part 5 of our deep dive, the Avengers of the hospital, or as the guidelines call them, the PERT.
The Pulmonary Embolism Response Team.
Yeah.
I really love that acronym, PERT. It sounds friendly, but they clearly mean business.
They really do. And the problem with silos you mentioned is very real and very dangerous. An interventional radiologist loves to use catheters because that's their hammer, so naturally everything looks like a nail to them. A surgeon loves to operate. A hematologist loves to use drugs. If you only call one of them for an opinion, you get their inherent bias. PERT brings them all together at once.
The guidelines actually include a figure 6 that maps this workflow out. Walk us through a code PERT. How does it happen?
So a patient is identified. Usually this is triggered for a Category D or E, and sometimes the high-risk Category C patients, those precarious C3s we talked about, the ER doctor or the hospitalist hits the proverbial button code P or T or sends out a rapid page.
And who answers? Is it like a bat signal over the hospital?
It varies by institution, but typically it triggers an immediate multidisciplinary discussion. Now, in 2026, this is almost always virtual. You get a rapid conference call or a secure group video chat with a cardiologist, a cardiac surgeon, an interventional radiologist, and maybe a hematologist or pulmonologist. They all look at the data together in real time. They are looking at the exact same CT scan images, the exact same vitals, in the exact same labs.
So they're all on the line saying, okay, looking at the CT, the right ventricle is huge, the lactate is rising, this patient is clearly a D2. What are we going to do right now?
Exactly. And they debate it and reach a consensus fast. Let's take them to the cath lab. Or, no, they're too unstable to move. Let's give systemic TPA right here in the ER. The immense value here is speed and shared decision-making. You don't have to call 3 different consults and wait for them to stroll down to the ER one by one over 4 critical hours. You get the hive mind instantly.
It effectively standardizes care so that your treatment doesn't depend on who happens to be on call that night. It flattens the variability that used to plague PE treatment.
That is exactly the goal. The guidelines strongly support PERT implementations to handle these complex, high-stakes decisions. It takes the individual ego out of the room and puts the patient squarely in the center.
So the PEER team is assembled, they've categorized the patient correctly, now they have to choose a weapon to fight the clot. Let's talk about Part 6, advanced therapies and clot busting.
Right. But before we get to the heavy artillery, we have to establish the standard baseline. Anticoagulation basic blood thinners is the absolute foundation for everyone from category A all the way to E. It stops the clot from getting any bigger and lets the body's natural systems do their work to break it down.
And the menu for blood thinners has changed over the years, right? Are we still using heparin and warfarin like the old days?
We are, but the preferences have definitely shifted. For the initial treatment in the hospital, especially for the sicker patients, categories C1 through E1, the guidelines prefer LMWH low molecular weight heparin over the old school unfractionated heparin the 4th drip, unless the patient is about to go into a surgical procedure or has severe kidney failure.
LMWH is the shot in the belly, right?
Yes, it's much more predictable. You give the shot based on weight and you know it works. The unfractionated drip requires constant blood draws and micro adjustments every few hours. And for the pills to go home on DOACs, direct oral anticoagulants like apixaban or rivaroxaban are the clear winner over warfarin, which is a VKA. Warfarin is notoriously finicky. You have to watch your diet closely, no big kale salads, and you have to get your blood checked every single week. DOACs are much more set and forget it.
So unless you have very specific contraindications, DOACs are the modern standard.
Yeah.
But let's talk about when those standard drugs aren't enough. When do we go in and physically or chemically attack the clot?
This is the realm of advanced interventions, and this is where the guidelines get very nuanced and very careful. We have 3 main ways to attack a clot beyond just basic thinners. Number 1 is systemic thrombolysis. This is the IV clot buster drug, usually Alteplase. You inject it into a peripheral vein and it circulates through the entire body, dissolving clots everywhere it goes.
Sounds incredibly effective, but also pretty dangerous, right?
Very dangerous. It carries a significant risk of major bleeding, most frighteningly bleeding in the brain, and intracranial hemorrhage. Once you push that drug, you can't really take it back. So it is strictly reserved for the sickest of the sick patients, category E1 and E2, and sometimes the crashing D patients. The high risk of catastrophic bleeding is only outweighed by the fact that the patient is actively dying of the clot.
Okay, so that's the nuclear option. What's number 2?
Number 2 is catheter-directed thrombolysis, or CDL. This is where the interventionalist puts a long tube through your veins, threads it through the heart right into the pulmonary artery, parks it directly inside the clot, and drips the medication right onto the blockage.
I see. So it's like a precision airstrike instead of a carpet bomb.
That is a perfect analogy. Because you're putting it right on the target, you can use a much, much lower dose of the drug, sometimes a quarter of the systemic dose. Less drug circulating means less bleeding risk elsewhere in the body.
That honestly sounds superior in every way. Why don't we just do that for everyone? Why risk the systemic nuke if we have the precision strike available?
That is the million-dollar question, and it's where the guidelines offer a rigorous reality check to the medical community. We intuitively feel like CDL should be better for everyone. But the guidelines state that for category C2 and C3 patients, remember those are the stable ones with heart strain, the benefit of CDL over simple blood thinners is unclear. It only gets a Class 2B recommendation.
Unclear. That's not a ringing endorsement.
Yeah.
We have all this amazing technology, and we don't know if it actually helps them.
It's not that we don't know if it clears the clot. We know it absolutely does clear it. It makes the heart look better on an ultrasound much faster. But does it actually save lives in the long run? Does it prevent long-term damage better than a pill? That is still hotly debated. The clinical data just isn't definitive yet. We don't want to expose stable patients to an invasive procedure and radiation if the outcome is essentially the same as just taking a pill. However, the guidelines do say that for high-risk patients like Category D, the pre-shock group CDL may be considered over systemic thrombolysis specifically to reduce bleeding risk.
So if I'm in Category D pre-shock and I'm at high risk of bleeding, maybe I recently had major surgery, the catheter approach is a much safer bet than the systemic IV infusion.
Correct. It's all about balancing the immediate risk of the clot killing you versus the treatment killing you. And then there's the third option, mechanical thrombectomy.
Which is basically the vacuum cleaner, right?
Essentially, yes. Using a large, specialized catheter to physically suck out or macerate the clot, no thrombolytic drugs needed at all. This is fantastic for patients who absolutely cannot have blood thinners because they are actively bleeding elsewhere. Maybe they have a bleeding stomach ulcer or recent brain bleed. You just go in and physically grab the clot.
And finally, the big one, the surgical option.
Surgical embolectomy. Open heart surgery, they put you on a bypass machine, cut open the pulmonary artery, and manually pull the clots out with forceps. It sounds extreme, and it is, but for a Category E patient who is crashing hard, or someone with a massive clot burden where the catheter vacuum just won't cut it, it can be absolutely life-saving.
The key takeaway here seems to be intense caution. The guidelines aren't saying, go attack every clot with everything you have in the arsenal. They are saying, respect the clot, but respect the treatment risks just as much.
Exactly. Aggressive therapy is mostly reserved for those in shock Category E or sliding rapidly toward it Category D. For the C categories, despite the really scary-looking heart on the scan, we're still learning. And conservative management with close monitoring is often the right call. We don't just do something for the sake of doing it.
So let's assume the system worked perfectly. The peer team met. They categorized the patient correctly. They treated them appropriately. The patient survived. Now we move to Part 7, the aftermath. You survive the clot. Are you just back to normal?
Ideally, yes, but not always. The guidelines heavily emphasize that PE is not just an acute event. It can have a long haul. We really worry about something called CTPD, chronic thromboembolic pulmonary disease.
This is where the clot just refuses to dissolve.
Essentially, yes. The body usually dissolves the clot over a period of months. But in a small percentage of people, maybe 2 to 4%, the clot organizes into this tough, fibrous scar tissue that permanently blocks the arteries. It's like concrete setting in the pipes. This can lead to severe pulmonary hypertension and right heart failure down the road.
How do we catch this before it ruins their life?
The 3-month checkpoint. The guidelines recommend that patients with ongoing shortness of breath or functional limitations after 3 months of standard anticoagulation need a full, comprehensive workup. You don't just pat them on the back and say, oh, you're just out of shape or it's anxiety. You investigate.
And what's the investigation? Just another CT scan?
Actually, no. The guidelines suggest a VQ scan. It's a lung perfusion scan. It looks at the microscopic blood flow and airflow mismatch. It's actually better than a standard CT scan for finding these chronic web-like scars. And you pair that with an echocardiogram to look at the heart pressures.
So if you're listening and you had a PE 4 months ago and you still can't climb a flight of stairs without gasping, go back to your doctor. You need a VQ scan.
Please do, because it's treatable, sometimes even fully curable with a specialized surgery, but you have to find it first.
What about daily lifestyle? I feel like the old medical advice was stay in bed, don't move. You might dislodge the clot and die.
That is incredibly outdated advice. The 2026 guidelines are all about early ambulation. Move around. Walking helps the calf muscles pump the blood and prevents brand new clots from forming. Strict bed rest is actually dangerous. It promotes stasis. Unless you are hemodynamically unstable in the ICU, get up and walk.
And what about travel? Everyone always asks about flying. Can I ever get on a long flight again?
The guidelines definitely address this. For long-haul flights defined as greater than 5 hours, compression stockings are considered reasonable. It's a Class 2A recommendation. They aren't fashionable. They are notoriously hard to put on, but they work. They physically squeeze the superficial veins and keep the deep blood moving.
Hey, I'll take safety over fashion any day of the week.
I agree completely.
All right, we have covered a massive amount of ground today. From the alphabet soup of A through E, to the PEERT squads and the intravenous vacuum cleaners. Let's wrap this deep dive up. The headline here really is the A to E revolution. A and B, you're likely, okay, maybe even go home immediately. C, watch closely. Your heart is annoyed, but it's holding on. D, the true danger zone. Pre-shock, the silent killer. And E, the emergency. Full shock and cardiac arrest.
That is the perfect summary. And if I can leave you with one final thought on the underlying why of it all, this guideline forces us to stop treating raw numbers and start treating the actual physiology. By defining normotensive shock in Category D2, the guidelines have fundamentally changed the entire game.
It raises a very provocative question to close on. How many stable patients, people sitting quietly in a hospital bed with a completely normal blood pressure reading, did we miss in the past 10 years? How many of them were actually in Category D2 silently failing from the inside out while we just looked at the monitor and nodded because the BP was 110?
It is a genuinely haunting thought. We probably missed quite a few. But with this new framework, with the intense focus on lactate and perfusion and that critical R modifier, hopefully we won't miss them anymore.
Precision medicine at its absolute finest. Thank you for joining us on this deep dive into the 2026 guidelines.
Yeah.
It's dense, it's complex, but it's undeniably a better era for patients.
It was a pleasure dissecting it with you.
Thank you for watching The Funnel Effect.